Hello. A very good afternoon, good evening to all the participants and students who are watching this video. So today I'll be actually moving to the final push in the subject like conservative dentistry and endodontics. I know you are in the last stage of your preparation, and I know you are in bit of tension and all. So basically talking about conservative dentistry and endodontics, what I actually saw in the previous question papers is like lot of the questions is repetitive questions. Actually say, see, when talking about conservative part, most of the cases like amalgam, we know the preparation part, inlay, the preparation part, and certain important questions like mercury toxicity, bevels, inlays, onlays, some repetitive questions I have actually seen. When coming to the endo part, when we take each topic, there are very particular questions being asked. Okay, when we talk about root canal treatment, nasal cavity preparation of molars, similarly, what are the various filing techniques, like what is circumferential technique? And when coming to the next steps, like the irrigation, what are the irrigants, medicaments, some of the important medicaments, and very importantly, you have to actually see to all the important recent advances, because what are the recent questions being asked is from the recent advances. Like when we talk about the perforation repair material, they are asking questions from what is mineral trioxide aggregate. They're asking about biodentine. Okay, so recent advancement is also been asked for your exams. Okay, and talking about your conservative part, the care is very important topic. So you need to actually keep an eye on that also. The diagnosis part, the detection part, the prevention part, the caris assessment methods is being actually asked repetitively. Okay, and your obturation. Obturation, there are a lot of obturation like thermoplasticized obturation is there. Your various lateral condensation. Each and every section has been actually asked. Okay, so you need to have an eye on that also. So I'm not actually extending our talk. I'll start with the first question. So like I have seen a lot of essays on avulsion and its management. So talking about fractures, not only avulsion, the fracture, root fracture is another important question. And from that, you have to know about vertical root fracture. So avulsion, we know that what is avulsion? So whenever you write an essay, what I need to say is like you have to give a content. So when we read the textbook, we have a content. After the content, we'll be actually starting with the introduction part, the classification, the description part, etc. Right. So whenever we deal with this topic, whenever we deal with an essay, it is very mandatory to write a content part. Okay. Once you're done with the content part, next you have to give an introduction. So I have not included all those such things because I like to actually discuss a lot of questions. So I have actually constricted only the important points that you have to write when considering each question. So talking about avulsion, you have to give the classification of avulsion, which classification comes, which Ellis classification, and coming to the management part, so whenever a tooth comes out of the socket, you can manage in two way. First is like at the site of accident, like we will get the tooth, either we can reimplant it. That is the management of the tooth or management of the avulsed tooth at the site of accident. Next is at the clinic. So we will be taking the tooth either in actually the storage media or like reimplanting, and we'll be replanting and we'll be actually going to the clinic. So management can take place in two part. So at the site of accident, okay, what happens is like if we get the tooth, as you can see in the image, as soon as possible, we can actually place the tooth into the socket. That is very important. That is a treatment of choice being considered. And if it cannot be done, so we can carry out in a storage media. You know, storage media, we have like even the saliva which we have in our mouth can be considered as a storage media. Even the milk, which is very easily available in our house, can be actually used, or simply the water can be actually used to prevent the dehydration, even though it is not an ideal storage media being used. So very important thing is like the how much fast or what is the speed of the placement of the tooth within the socket determines the outcome of the treatment, and we have to prevent the drying. That is very important. That is why we actually rely on the storage media and why we actually place the tooth within the socket, because we know that the tooth surface actually consists of the periodontal ligament cells, as well as various periodontal ligament attachments, which is actually required for the tooth to firmly be there in the socket. So that periodontal ligament has to be actually preserved to prevent the dehydration or the loss of the physiological or normally present PDL. We actually use the storage media. And it is very important that every effort should be done to actually replant the tooth within like 15 to 20 minutes. Okay, that is the time till which the PDL can be actually have a full-fledged action. So whenever you write a question or an answer from a fracture, always try to write this term, International Association of Dental Traumatology. Because as we know, we have conservative subject, pedo subject and all. There is a particular association, that is the IADT, who always gives guidelines how to treat the various stages. Okay, how to treat the various like stages of fall or trauma, etc. So they have actually given, first is like keep the patient calm, find the tooth and pick it with the crown. Never actually use the root part, and make sure it is the permanent tooth. That is very important. Never actually use the primary tooth and avoid touching the root part. So if the tooth is dirty, we can actually wash it with a 10-second maximum in the cold running water, and never actually scrub the surface, just reposition. And once the tooth is actually back in place, ask the patient to bite so that it holds in the position with the help of actually a handkerchief. In this way, the extra alveolar period can be actually reduced so that the PDL cells and PDL ligament will be actually preserved as such. Okay. Next. Sorry for the interruption. So there was a technical error. So if the tooth is dirty, wash it for actually 10 seconds, and we have to place it for in a cold water, as I told, and we have to place that in actually the tooth structure with the help of actually handkerchief, and so that it firmly goes into the socket. Okay. Next important, so these are the points by the IADT 2012 for actually placing into the socket. So when replantation of the avels tooth is not possible, so we have to actually transport either in the saliva within the mouth, or we have to actually place in a media. That is very important. Okay. So next is like once we have actually dealt with this situation, next is like the dental treatment. We have to seek the emergency dental treatment immediately. So another important short note that has been actually discussed is like what are the types of what medias that is used. So medias can be actually classified into two types: natural medias and synthetic medias. Natural medias mainly have been again classified into good accessibility and poor accessibility. So good accessibility means which is like very easily got, like the milk, coconut water, egg white, the saliva, water, etc. Poor accessibility like the red mulberry, propolis, green tea extract, honey milk, aloe vera, pomegranate juice. It is actually poor accessible things. Now coming to the synthetic part, all these were actually the natural materials. So coming to the synthetic part, which is having a good accessibility, include the normal saline and gaturate is there, contact lens solution, ORS, and risitral is actually considered to be the synthetic material with good accessibility. And which is poor accessibility is like the HBSS solution, which is considered to be the most important or good storage media, and the organ storage fluid culture media. So whenever such a question is being asked, you have to write what is the use of a storage media. You have to write the classification of storage media and give a advantage and disadvantage of each of this storage media. I have just actually included this. You have to write when an essay is asked, and you have to write when a short note is asked. So coming to at the clinic, so till now we have actually discussed what happens when a tooth is actually avulsed and what we do at the time of actually the trauma. So now we have actually come to a position where the patient is coming to the clinic. Okay. So clinic, the treatment is divided into two. Either it is a closed apex or it is an open apex. So closed apex is, it is divided into three. Please keep this in mind. First, the tooth is brought and replanted at the time and they arrives at the time of that accident. One. Second, the extraoral period is less than 60 minutes. Two. Three, the dry period is actually more than 60 minutes. So this three important classification you have to write whenever you write this question. Next is when open apex is seen. First of all, again this three classification when the tooth arrives at the time of accident. Second is like when the time period is less than 60 minutes, and third is like the dry period is more than 60 minutes. So this is actually the classification that you have to actually keep in mind. So first of all, when the patient has been arrived or the patient has been replanted before the patient arrive at the clinic. So what does that? Leave the tooth in that place. We have to clean that area with the help of water, saline and chlorhexidine. And if there is a gingival laceration, we have to actually suture that area and always verify the position of the replanted tooth by giving a bite both clinically as well as radiographically. Okay. And after that, the patient is asked to actually wear a flexible splint for actually 2 weeks because 2 weeks a review is required because there is high chance of ankylosis. To prevent that, a flexible splint is actually given. After that, we have to give the antibiotics for the infection to heal, etc. And the anti-tetanus therapy has also to be given. And after that, we have to actually give the root canal treatment after 70 days after reimplantation. Okay, that is very important. So that was the first part when the tooth has been replaced at the time of trauma and the patient comes. That is first what we have actually studied. Second, if the extraoral period is less than 60 minutes. So what you have to think is that whenever the extraoral period is less than 60 minutes means some of the periodontal liquid might be actually there which has been preserved. Okay. So we have to prepare the root and the root preparation is done depending on like whether it is having an open apex or a closed apex, and on the dry time of the tooth before it was placed in a storage media. So a dry time of 60 minutes is considered the point where survival of periodontal cells is unlikely. Okay. So if it is actually a closed apex, so what we have to do is like since it is less than 60 minutes, we have to clean the root surface with the help of saline, as well as what we have to do is like soak the tooth in a saline, thereby removing all the contaminants, dead cells, etc. Okay. If it is not effective, the dirt is even removed with the help of a gauze, okay, which is also soaked in saline, okay, so that it will help for the tooth to get properly attached to the tooth surface. It should not be contaminated. Okay, then what we do is like administer local anesthesia, irrigate. You can see that image, irrigate the socket with saline. After that, we'll be placing the tooth inside the socket with digital pressure, and we can actually again suture that area and flexible splint for 2 weeks. And into that, what we have to do is like after that, if the tooth is non-vital, go for actually root canal treatment. When it is an open apex, so we have to do the revascularization procedure. That is because the root has to close, right? So we can actually place the method of revascularization technique and topical application of antibiotics. That is very important. Especially we'll be soaking it in doxycycline 1 mg in approximately 20 ml of the physiological saline for 5 minutes or cover with the help of minocycline. So these are the important points which they'll be actually looking for whether you have actually attempted or not. Okay. And after that, we can do the root canal treatment. If the extraoral dry time is more than 60-minute, what? The entire PDL cells will be necrotic. So we have to this is called as delayed replantation. So the surface has to be actually cleaned properly. All the cells has to be actually removed and a root canal treatment has to be actually done. And very important, in case of root canal treatment, or before the replantation itself, we have to do the root canal, then only place within the cavity. So the socket should be actually irrigated properly with saline, etc. Okay. Again, you can give a splint, etc. And similarly, the tooth should be soaked in 2% sodium fluoride for 20 minutes or 2% stainless fluoride for 5 minutes. That is very important. Then only replant, because as I told, the entire periodontal ligament cells has been destroyed. So we have to remove the necrotic pulp and the PDL should get into attachment with actually the tooth surface. So that is very important. Okay. Along with stannous or sodium fluoride, we can use tetracycline, citric acid, hypochlorous acid. That is to a very small amount which has been actually used to inhibit resorption. So resorption is normally seen. To prevent that, normally this has been actually used. Okay. So this is, as I told, on the root surface, you can see the image. It is dirty. It will be actually scraped off to remove the necrotic PDL and PDL ligaments, and we'll be actually using the sodium fluoride treatment. After that, we'll be doing a splinting therapy, and the patient radiographically as well as like clinically it will be tested, review will be given, splinting will be given. So this is what is actually happening. So very important thing that you have to write. The treatment is divided into two sections. First is like at the time of the injury. Second is like at clinic. So at the time of actually injury means we will be replanting. Otherwise, take it in a storage media. Understood? At the clinic, it is divided into two: open apex, closed apex. Open apex 3 treatment, closed apex 3 treatment. Open apex, you can at the time of injury, less than 60 seconds, more than 60 seconds. Similarly, in the case of closed apex, whenever there is closed apex, go for a root canal treatment, treat the surface of the tooth, and whenever there is an open apex, go for revascularization procedure, because the closure of the root has to be taken place. Another important is like surface treatment is very much important, like the tetracycline treatment or the stannous fluoride, sodium fluoride, etc. has to be actually treated. Okay. So those were the very important headings from the part of avulsion. So please keep that in mind. So next very important and expected question is actually the cast restoration. So talking about cast restoration, most of the question might be like talk about inlays. The question will be like inlay. So or have a note on the cast metal restoration. So we know that cast metal restoration, as you all know, it is fabricated outside the oral cavity, that is in a lab setup, right? So cast metal alloy are used for the entire restoration or maybe designed as a substructure and veneered with the porcelain. Okay, so Taggart was the person who introduced the cast gold restoration in 1907. So that is the introduction, but that you have to write when an essay is being asked. So talking about inlay, you have to give a definition. The Studman 7th edition have given a definition of course, you can see the image. It is an intracoronal restoration that mainly involve the occlusal surface and the proximal surface of a posterior teeth and may cap one or more but not all the cusp. Okay, that is the definition of inlay. So that is very easy, right? It is an intracoronal restoration which involves the occlusal surface as well as the proximal surface and may cap one or more of the cusp. So again, we know that normally we follow the fundamentals of tooth preparation, right? You know that the outline form is there, primary resistance form, primary retention form, convenience form. Then coming to the secondary, the secondary steps like the secondary resistance retention form, all those things. Similar headings comes in inlay also. Okay, whenever essay is asked, you have to write this fundamentals of tooth preparations also. So talking about an outline form always include three important general principles. all the weakened enamel, we know all the weakened enamel margins, etc. should be actually removed. That is one. All the false cavities should be actually included. Second, all margins should be placed in a position to afford good finishing. So that is the three important outline things that you have to keep in mind. And similarly, why enamel margin strength is preserved? How we'll preserve an enamel margin strength? That comes under the outline. Okay. So two significant features like it actually is formed by a full-length enamel rods whose inner ends are on sound ending. Second, these enamel rods are buttressed on the preparation side by progressive short rods. So this 2 point you have to actually write when the enamel margin strength is being written in the outline form. Okay. And similarly, whenever the outline form should be have a width. So normally in amalgam, it is 1/4. In the case of cast metal, it is 1/3 the intercuspal distance and a depth of 1.5 from the central pit. You can see that image 1.5 from the central pit. So that is all about the outline forms you have to write. Next is the primary resistance form. We know that flat floor will be there. All the internal angles should be rounded off. The thickness of the restorative material should be there to prevent the fracture under the load. Hope you understood. So primary retention form means you should have a parallel wall or there is actually 2 to 5 degree taper is there in single wall. Occlusal dovetail is there. Masticatory load should be directed to the seat, directed to seat the restoration. So talking about convenience form, mainly the occlusal divergence of the vertical walls, not it is the vertical walls they are talking about. And there should be a clearance of 0.5 mm. You can see in the second image, 0.2 to 0.5 mm. Why that clearance is required is like for proper finishing and polishing of the material and in order to take a proper impression and for trying of casting. Hope you understood. So now we have studied the outline form. Talk about the enamel margin strength in outline form. Second, primary resistance form, retention form, and convenience form. So the final tooth preparation steps, as we have studied in amalgam, like we have to remove the remaining pits, fissures, old restorations. If there is a requirement of pulp protection, we have to actually give. So talking about the KO surface margin, but we will be giving bevels and flares here. So KO surface margin will be actually explained in the next slide. Another short note that has been asked for you people is which is a secondary resistance and retention form for an inlay or a cast metal restoration. It complained GIL. You can memorize like G for grooves, I for the internal box, L for the luting cement. Even the external boxes are also there. At least you write these three. First are the grooves, internal box, and the luting cement. Okay. So secondary retention form for cast inlay. First is a luting cement. So we know luting cement is a cement that we apply for actually placing the cast restoration on the cavity, right? What happens is like they fills the space between the tooth and the cast and they actually fills the irregularity and there is a proper physiochemical bonding that is actually taking place. Okay, that is the advantage of luting cement which provide a secondary retention form. Next is actually the reverse bevel. You can see the image of reverse bevel. This is the reverse bevel. It is actually placed on the expense of gingival flow, creating an internal dentine plane. You can see there is an internal dentine plane that is actually placed in the gingival axially and it helps in actually locking the restoration and they prevent the displacement of the proximal restoration. Okay. And it is mainly indicated in the class 1, class 2, class 3, class 4. And in class 4, it is very much less common. Okay, since it is anterior tooth. It is contraindicated in a cast ceramic restoration. So now you got two. First is luting cement. Second is reverse bevel. Third is grooves. Grooves are mainly of two types, internal grooves and external grooves. See, internal grooves you can see it is placed internally within actually the cavity so that an additional retention is actually produced. But never where it is contraindicated when there is a chance of impinging the pulp, there it is contraindicated. While the case of an external groove, you can see in this image, it is actually placed on the surface of actually the preparation, and especially placed on the periphery of the surface to prevent the displacement of tooth. So hope you understood the three things. First of all, we studied about luting cement. Second is reverse bevel. Third is grooves. Grooves are of two type, internal grooves and external grooves. Next, coming to the internal box. So as you can see in the image, this is actually one of the most efficient method for actually providing an secondary retention and resistance. So you can see there is actually preparation of a small box or slot. Normally, it provides 4 to 12 times more retention, and it is actually located next to the marginal ridge with the intact proximal wall as on the wall. Hope you understood. It is advisable to place the internal wall at the periphery of cavity. Understood. Next, coming to actually the external boxes. External boxes, you can see as the image it is seen, there is an outside box that is shaped within the cavity, and there is a proper extension of the cavity that is actually taking place, and there are seen at the proximal surface, facial surface, as well as actually the lingual surface. Hope you are understanding. And they can be even placed or on the occlusal surface, gingival surface, and never be on the step. That is very important. They are peripheral, as well as the portion should be flared, and it should not be actually, it should be actually beveled. So that was a very important topic on actually the external boxes. Next is talking about slots. So slot, what is the advantage of actually a slot? A slot is actually a slice that is prepared on the dentine of an unaffected side. That is very important. So slot should have the important dimension: mesiodistally the width of the burr, faciolingually 2 mm, depth of 2 mm. That is the thing that you have to keep in mind. Slot is actually prepared on the dentine of a unaffected side. Okay. Normally, width is like mesiodistal width is the width of actually the bar. Faciolingually, it is actually on the 2 mm, and depth of actually 2 mm. Okay, hope you understood this much point. This is a very important topic whenever cast metal restoration is given. Most of the people will be writing only about the bevels, circumferential bevels. So you have to write the secondary resistance and retention feature also. Like the luting cement, reverse bevel, you will be writing the grooves, like the internal groove will be there, the external groove will be there. And similarly, you will be actually having Hi students. Sorry for the interruption. I think there were certain technical errors that happened while connecting the YouTube as well as the Zoom link. So sorry for that. I think the Zoom, like YouTube, till the traumatic injuries was actually dealt. So now we'll be actually dealing with the cast restoration. So talking about class restoration. Uh, Cast metal restoration mainly talks about the inlays. Okay, so whenever you see a question on inlay, you need to write about like this question or the cast metal restoration. Okay, cast metal restoration are complex indirect restorations which is actually fabricated outside the oral cavity, especially it is lab fabricated. Okay, where the entire restoration may be actually designed as a substructure and it will be actually veneered to the porcelain. So Taggart was a person who actually introduced gold cast restoration in 1907. So talking about the definition of inlay, inlay's definition was given by Studman's 7th edition. So talking like it is an intracoronal restoration that involves, you can see the image, it involves the occlusal surface as well as the proximal surface of a posterior teeth and may cap actually one or more, but not all the cusp. So that is the thing that you have to keep in mind. Inlay is actually a restoration, so it is involving the occlusal surface as well as the proximal surface of the tooth structure. So you know whenever we write an amalgam restoration, we'll be actually following actually placing the fundamentals of cavity preparation steps here also. So talking about the first step, that is the outline form. So outline form, talking about outline form, it actually it involved all the fragile and the weakened structures will be actually involved first. Second, all the faults should be actually included. Third, the margin should be placed in such a manner it actually afford a very good finishing of the margin. So these three important things you have to write when you write the outline form. And second is like the enamel margin strength is being actually written in the outline form because it is actually formed by full length enamel rods where the inner end are on sound ending. That you have to keep in mind. And these enamel rod are buttered on the preparation site by the shorter rods. So this enamel margin strength should also be actually written here. Okay. So next important point, the cavity width should be actually 1/3 of the intercuspal distance that you have to see. And normally we have 1/4 in the case of amalgam, right? And initial depth of 1.5, as you can see in the image, should also be actually written. Next is the primary resistance form. Normally it should be actually a flat pulpal floor. All the internal angle should be rounded off and a proper thickness of the restorative material should be there to prevent the load. Primary retention form normally parallel or it should have a taper of 2 to 5 degree per wall and occlusal dovetail should be there. Masticatory load should be directed to seed the restoration. Convenience form is like we know that occlusal divergence. Normally, inlay have an occlusal divergence. So occlusal divergence on the vertical walls, that is a convenience form. And you can see in the image there is a clearance of 0.5 mm that is seen. Why a clearance of 0.5 mm is required to allow for a proper finishing of the preparation, for proper accurate like impression taking and for trying in the casting. So final preparation stage, as we have already studied in amalgam, it is like the removal of the pit and fissure, all the old restorative material. If the pulp is not protected, we have to give a pulp protection agents like the zinc phosphate, GICs, polycarbonate, etc. has to be actually given. And KO surface margin will be discussed in the coming slides. And here you have to write about bevels and flares. So most of the people write about bevels and flares, but they never write about the secondary retention and resistance form. In the case of inlay, if you write the coming slides only, you can fetch good marks. Understood? So secondary resistance and retention forms include, you can memorize like GIL. Okay. It's like G for the grooves, I for the internal box, and L for the luting cement. So we know that luting cement is actually seen between the inlay as well as the tooth structure. Normally they wet the tooth structure. It actually remove all the space that is between the tooth and the cast structure, and they remove the irregularities, etc. And they form a physiochemical bonding between the tooth structure as well as the restorative material, and that is about the luting cements. And normally we'll be giving something called as actually the reverse bevel. As you can see in this image, the reverse bevel is actually placed in the expense of a gingival floor, and it is actually produced in an internal dentine plane in a gingivo-axial inclination is given. So they are created by the gingival margin trimmer. Normally it is actually indicated in a class 1, class 2, class 3, but least indicated in a class 4 cast material, contraindicated in a cast ceramic material. So now you got the secondary resistance and retention, two resistance and retention feature. First is luting, second is reverse bevel. Very important point that you have to keep in mind is like, whenever you write this question, you have to write the secondary resistance and retention form. One. Second, sometimes the question is like short note on the secondary resistance and retention form for cast inlay. So please keep these important points in mind. So talking about groove is always located completely in the dentine. Okay, there are two types of groove. As you can see in the image, there are internal grooves over here. There are external grooves over here. So the internal grooves are actually always placed within the tooth, and the dimension of the cavity are fairly limited. The contraindication is like, we know if the pulp is actually very much large, if there is chance of damaging the pulp, a internal groove is contraindicated. While in the case of external groove, as you can see in the image, it is actually placed outside the tooth, and it is actually placed in the periphery of the tooth. Okay. So that is the fourth one. So luting we studied, first one. Second, we studied about the reverse bevel. Grooves, two type, internal bevel, external bevel. Okay. Next is boxes. As you can see in this image, there is a box that is placed within internal to the cavity, which is a very important step for immobilization of the restoration. So it is actually prepared in the dentine with all the four vertical surrounding walls located, and it can provide about 4 to 12 times the retention when compared to the external boxes. And as you can see, it is actually mainly placed near to actually the marginal ridge with the intact proximal walls. Okay. Next is external wall. As you can see in this image, the external wall or the external box. So this is the external box. Preparation is actually done and the axial surface with a 5 wall surrounding them. And they can be in the proximal side or involved in the lingual side or the facial side is there. They are always stepped. They can be actually stepped occlusally or gingivally, but not steeped. Okay. So that is a three or four important point that you have to keep in mind. It is actually box shape placed on the external wall, especially in the axial tooth structure, involving 3 or 4 or 5 surrounding walls has been included. Next is a slot. A slot is always placed in actually a dentine. And another important point is like slot, the dimension is very important. Slot, the mesodistal width is width of actually the burr. Facial-lingually, it is 2 mm, and gingivally, it is also 2 mm. Okay, those were the secondary and resistance form. So another method how we can actually increase the resistance and retention form is like grossly roughening and irregularizing or multiple leveling the surface of preparation. So you can see the image. Leveling is done in different directions so that it can actually provide a proper retention. That is, irregularity is actually done. So you can see the pulpal floor or the occlusal surface. A large amount of irregularity is being actually placed so that they form a proper interlocking between the restoration and also the tooth structure. So you can use a fissured burr for actually effectively giving a gross roughening on the surface of the pulpal floor or the occlusal floor. Next is post. Post is another method of actually the retention for a final cast restoration that also you can actually write. And next is there is something called the pre-cementing grooves. So before we cement the cast metal onto the tooth structure, there will be a inverted truncated cone shaped groove where it is cut on the casting and opposite it on the tooth preparation, similar to that of groove, which can give a more of a retention. Okay. Next is electrolytic etching of tooth structure. That is another method of actually increasing the adhesion or the retention and resistance form, where the etching time is about 10 to 15 minutes. Hope you have noted all the important headings. So these are the secondary resistance and retention forms: luting cements, reverse bevel, grooves like internal groove and external groove, box like internal box and external box, slots are there, gross, irregularity preparation, post placement, pre cementation grooving, electrolytic etching of the tooth surface. So these are the very important methods of secondary resistance and retention form. Next, sometimes the question will be like, for your essay, what are the principles of cavity preparation for inlay? So you have to write there is a preparation path, inlay taper, preparation feature, or the circumferential tie. So most of the people know this, the circumferential tie, because the bevels come inside that. Okay. So preparation path is like, we know either it should be parallel. So there should be a taper of 2 to 5 degree taper per wall. Each wall should have a degree of 2 to 5. Okay, that is very important for proper impression so that the material can be placed inside the cavity, etc. Okay. So what is a circumferential tie? It is actually the peripheral anatomy of a propeller, how we place the periphery. Normally we give what bevels and flares are given. Again asked short note. So you have to know what is a bevel. Bevel is actually an abrupt incline between tooth surface, either the prepared tooth and also the cavity wall. Okay, that is very important. And bevel, why we give a bevel? Normally it is actually at a, this ankle is very important. 140 to 150 degree marginal enamel is given, while like a marginal metal of 30 to 40, that is forming 180 degree. Means the enamel is like for 140 and the remaining what 40 forms what the metal. So that is how they complete that 180 cycle. So if it is actually 150 degree of marginal enamel is there, there will be 30 degree of marginal metal being placed. Okay. So types of bevel, very important. Again, you have to know there is partial bevel, short bevel is there, long bevel is there, full bevel, counter bevel, hollow ground bevel. All these things you have to draw as well as you have to write where it is indicated. Reverse bevel, we have already studied that. It is an extension into the gingival floor. It is actually a secondary resistance and retention feature. Something is there called as occlusal bevel. As you can see here, occlusally a bevel of 40 degrees actually given. Very important. Next is gingival bevel. Gingival bevel, as you can see here, there we'll be giving at an angle of 30 degrees. These numbers you have to actually keep in mind. And this is having a thickness of 0.5 to 1 mm width is actually there. Why it is done is like there should be proper like blending of the secondary flare and the restoration, etc. has to be done. That is why we actually provide a gingival bevel. Now, what is a flare? Flare are the flat surfaces or a concave preparation on the facial and the lingual proximal wall. And there are two type primary flares, and which is seen on the outside is called as actually the secondary flare. Okay. So primary flares are a very conventional flare. As you can see in this image, primary flare are the basic part of a circumferential flare, and they diverge on the buccal and the lingual aspect at an angle of 45 degree, that you have to keep in mind, and it bring a buccal and lingual proximal cavity which helps in the proper cleaning and finishing. So talking about secondary, that is actually outside, which is a superimposition to the primary flare. It is at an angle of 40 degree. This was 45, that was actually 40 degree for proper adaptation. Now you have to know what are the burrs that is used. Normally a number 271 burr, 169 burrs and 8862 burrs are actually used. So I have given a difference. This will be very helpful for you to write your exam. Sometimes the question might be, what are the difference between a cast inlay and amalgam restoration? See, cast inlays, we know very extensive preparation is there, right? But amalgam, it is kind of a conservative preparation. Young tooth cast inlay is not indicated because the cavity is very large. It is occlusally divergent, not converging like that of amalgam. So, but amalgam can be indicated in a young and old tooth. Cost is more for the case of an inlay because it is done in labs. Cost less in the case of an amalgam. Normally, for an inlay, we use a 271 burr, while in the case of an amalgam, we use a 245 burr. The axial wall, we know normally we'll be actually giving either parallel or slightly divergent occlusally with 2 to 5 degree on each wall. While in the case of amalgam, it is by an occlusal convergence. Okay. And we'll be given occlusal bevel of 30 to 40. Normally in amalgam, we never give a bevel. And only gingival bevel is given for amalgam. In the case of an inlay, we give 30-degree bevel. In the case of amalgam, 50 to 20, just the half of the inlay. The proximal box is box shaped in the case of inlay. It is inverted truncate in the case of an amalgam. Cavo surface angle we know normally 90-degree for the case of amalgam, that is called as the lap butt joint. But in here we know it is 130 to 140-degree lap joint. That is why metal margin 140 minus 180, that is 30 to 40. Metal margin in the case of 90, because 90 is the K O surface angle, the remaining metal will be 90-degree, right? So flares are not indicated in amalgam, flares are indicated in this thing. Intercuspal distance is 1 by 4th in amalgam, 1 by 3rd. This is a very important box. Even though you don't study anything, I want you to study the secondary resistance and retention forms and this box as such. And that three important principles for a cast inlay preparation, that also you have to keep in mind. Another important is like, as I told you, you'll be writing about the bevels and flares. You can write the the extra coronal and like marginal anatomies like the chamfer finish lines, knife edged finish lines, beaver shoulder finish line, and hollow finish line. This is very important. I'm not explaining. You have to know the various bevels. Okay. See, this is another question paper where the question has been asked is like, classify composite, enumerate the various uses, describe the step-by-step procedure of restoration of a class 4 defect on an upper central incisor using composite resin. So, the question has been asked for, again, for 6 plus 4 plus 4. Classify composite that you will be studying. I'm not explaining. Enumerate the various uses you know. But you know the step-by-step procedure, whatever we do when we give composite. So whenever you write essay, you have to write contents like this. Introduction, a case selection and shade selection is what we do. After that, we'll be isolating the patient and the cavity design will be selected and the restoration will be actually giving the matrix placement, how we'll place the composite, how we'll contour, shape and polish and finally we'll be doing an occlusal check. So first is like case assessment is like we have to examine how much the caries has been gone both clinically and radiographically. Like you think what we do in a clinical practice, only that is what is happening. We have to do a shade selection before the tooth dehydration. That is very important in a natural light under a shade guide and occlusion should be actually tested. Okay. So next is like isolation has to be done. We know that moisture control is very important for the success of a composite restoration. Mainly we give a rubber dam, which is considered to be the ideal isolation method, and cotton rolls with salivary ejectors are also being actually used. And you can see as in the image, it helps in actually retracting the gingiva. And this can be actually accomplished again with the help of a retraction cord. So cavity are normally of like three important: conventional cavity, beveled conventional cavity, and one more is the modified class 4 tooth preparation. So this has been taken from Studwins. So conventional cavity is like it has been used in the following situation, as you can see in the image, like a very high stressed area, and it remove caries with the help of a round burr or a spoon excavator. The preparation is a box-like cavity, you can see, with the facial and lingual wall is parallel to the long axis of the gingival floor and it is perpendicular to the long axis. So that is very important. So as you can see in the image, it is having a box shape where the facial and lingual will be parallel to each other and the gingival floor will be perpendicular. All the weakened structure should be removed, 0.5 mm into the dentine, and we have to create a bevel of 0.5 to 1 mm. This is the normal cavity preparation which we do. Please keep this in mind. Beveled is like the beveled convention is indicated for a very large proximal, as you can see in the first image. So what we do is like arbitrary like dovetail will be actually seen in the lingual surface, and this will actually enhance the retention. Next is like the bevel is prepared at an angle of 45 degree, as you can see in this image, 45 degree to the external tooth surface. What we use is like last time we used a round burr, right? Here we'll be using a flame shaped burr, or a round diamond burr will be actually used. So what is the width of a bevel? Since this is the beveled conventional preparation, it will have a thickness of 0.25 to 2 mm. So that is very important. Okay. So cavity preparation, first we studied about the conventional preparation, very easy, just a box. Second, box plus a bevel of a thickness of 0.25 to 2 mm. And again, we can again, as I told, there will be dovetail on lingual side, and even we can place some, see, retention undercuts is actually placed with the help of a grooves, with the help of a 1 by 4 bar, that will give more of a retention. Next is the modified class 4 preparation. So modified class 4 preparation is mainly for a very small and moderate cavity. Till the last two we studied for large cavity. Here it is for actually a moderate cavity. So the objective is like to remove a very small tooth structure. There will be no grooves, no coves. Usually is actually indicated. Understood. Normally the retention is because of the bonding agent to the enamel and dentine with the help of composite. So now you studied first step, how is the case selection? Second is the shade selection. Third is the proper isolation method. Fourth is actually the cavity preparation. Next, what you know, etching, priming, and placing of the adhesive. That you know, we'll be actually placing etchant for 10 to 30 seconds, and we'll be washing that, air drying that. Then we'll give a bonding agent. Again, we can give a matrix application. See, as you can see in this image, we can provide a silicon putty index as a palatal index to that the composite can be can be actually done. A triangular shaped wedges is indicated so that the shape of the gingival sulcus is being actually got. Normally we'll place the toothpick, as you can see in this image, there's a toothpick being placed. Okay. However, normally we place a composite in the form of an incremental technique. So incremental technique, you can see here a palatal shelf is actually made. It places a palatal crown form or a silicon index is actually placed inside. Then we'll place a small amount of enamel, thin layer of enamel or a translucent composite. This is a translucent composite, and will be cured for 20 seconds. On top of that, we'll be placing dentine layers, like the opaque dentine shades will be actually used on the surface. As you can see, the base was given with enamel. On top of that, we will be giving various shades of dentine. And next, the proximal wall is done with the help of a mylar strip, and it is done with the plastic filling instrument, even with the help of actually a finger pressure through the mylar strip, which provide a tight contact on the smooth surface. After that, on top of this surface, we will be actually providing a what? Enamel shade. So enamel shade was on base. On top of that, we gave dentine, and proximal sides were actually prepared, and that, finally we'll be giving a enamel layer. After that, we have to contour the structure. As you can see, the natural tooth structures like the lobes, the line, ankles, incisal translucency, etc. has to be made. Normally, it is made with the help of a flame or foot-shaped burrs and a tapered fissure burr. Next is like after that we have to finish the surface. Normally abrasive discs are soft flex. Example is soft flex. It have various shapes like coarse, medium, fine, super fine, etc. has been actually used. And interproximally we'll be using an interproximal finishing strips for removing the unwanted composites and the extensions in the contact area. So please keep these names. Polishing, silicon polishing cups are there. Felt disc with polishing paste are there. High gloss polishing paste are actually used, like which contain aluminum oxide as a polishing agent is there. And another important is like a disc example, like a super snap disc is actually also used for creating the uh, embarrassures, etc. is being actually used. Lingually, the excess of composite is removed with the help of a round or a oval 12 bladed carbide finishing burr is used. A very sharp gold knife or an amalgam knife or a number 12 scalpel blade is being actually suited for removing the gingival proximal area. Next, after that, we have to check the occlusion with the help of an articulating paper, and we'll be asking the patient to sit in a centric and eccentric motion, and we'll be rechecking and reducing the occlusion. So, hope you understood all those things. So, whenever you write this like question, what I have noticed is like most of the time this question has been asked. So, go for the cavity preparation, the normal steps of composite placement, wedges, mylar strips that is used, uh, various burrs that is used, various finishing discs that is used, various polishing discs that is used, and check the occlusion. Next, I want to talk about a very easy question, biodentine. This is a recent advancement. So we know that there is two important things like MTA and biodentine. These both are silicate-based cement. But sometimes the question might be like, what is MTA? Talking about MTA, everybody know that is mineral trioxide aggregate. So normally it was found by Toraminjan in the year of 1993 in the Loma Linda University. Okay, so MTA, just note this differences. Even you can write when a question has been asked in perforation repair or an apexification procedure is being MTA and biodentine has been actually used. You can actually apply this answer there also. So powder liquid ratio is like MTA 3:1, biodentine 1 capsule and 3 drop of liquid. Important thing is like setting time. See, MTA it is too much like 175 minutes. That means that about 3 hours MTA it takes MTA for to set. But in the case of a biodentine, it takes only 10 to 12 minutes. So it is very less when compared to that of MTA. So that will be very reasonable for us to use what biodensity. So density is 1.8. Porosity is 22.6 when compared to biodensity. And very important is like MTA have a very excellent sealing property, but these important differences you have to know, right? And when talking about MTA, you have to know the pH. There are two type of MTA, gray MTA and white MTA. You have to know that composition also. Everything is based on silica, tricalcium silicate, dicalcium silicate, tricalcium aluminate. So a lot of silica based material is being added as the composition. Okay. Next important question is irrigant. See, the irrigant has been asked as an essay. Classify irrigants. Mention the role of irrigant in the success and write a known of chlorhexidine. So even there are a lot of other questions like, see, you can see this question, sodium hypochlorite, classify intracanal medicament and write a note on calcium hydroxide. What are the ideal requirement of intracanal medicament? What are the recent advances? So a lot of questions have been actually asked from irrigants. So talking about the content, you have to give an introduction. So why we need irrigation? As we know, our root canal is a three-dimensional structure which consists of large amount of complexity, including the root canal system, large amount of dentinal tubules, microorganisms, etc., where the instrument cannot reach. So we need an alternative which can flush out all the microorganisms, debris, dissolve the organic and inorganic materials, etc. There comes irrigants. So goals of irrigants include debridement, everything which we know, tissue dissolving, organic tissue dissolving. It should be non-toxic. It should have low surface tension, lubrication action, and removal of the smear line. Next is actually the factors influencing the efficiency of root canal irrigants. So quantity. So more the quantity, more will be the action. Shielder told that at least 1 to 2 ml each time should be used for flushing, which will have a good effect. Frequency, more the frequency, more will be the action. Concentration, again, Grossman did a study where he used in a dampened dish, he placed 5.25 percentage of sodium hypochlorite and onto that he placed a pulp. So the entire pulp got dissolved in 30 minutes. So he told that always 5.25 percentage of sodium hypochlorite for 30 minutes. Next is like the temperature. Whenever we heat the solutions like sodium hypochlorite, it will have an enhanced effect. So whenever we use solutions like this, always heat that to 37 degrees Celsius. So more the length of contact means more the action of the irrigant. Okay. The gauge which we use as an irrigation needle should be like 30 or 28 gauge needle. So classification is very important. You can memorize like chemical mediators and natural media. So chemical media, you can memorize like CAT. I have given a mnemonics like CAT. C for chelating agent, A for antibacterial action, and T for tissue dissolving agents. Natural agents are like the green tea, triphala, etc. has been actually used. And another important thing is like CAT, C for chelating agent. Normally, chelating agent is actually the EDTA, and antibacterial action is like the chlorhexidine, and the tissue dissolving action is by sodium hypochlorite. So sodium hypochlorite, it is called as a bleach. It is having both antimicrobial action. Mainly, it dissolves the pulp. That is why it dissolves the organic tissue. So this is very important. See, sodium hypochlorite, what happens is like when it reacts with water, they form two important NaOH and HOCl. This HOCl is very much stronger, which is actually responsible for the antimicrobial action. So you have to know three important reactions: saponification reaction, neutralization reaction, chloramination reaction. Because why I'm saying this is like the question has been asked as sodium hypochlorite. So if you don't write all these things, there won't be anything to write actually. So there are three important reactions that is shown by sodium hypochlorite. First is saponification reaction, means the sodium hypochlorite, as you can see in this image, sodium hypochlorite go and react with the fatty acid and they transform into soap and glycerol. That is first. They neutralize the amino acid, that is the neutralization reaction. Chloramination means they form the hypochlorous acid and they actually combine with the protein to form chloramine. So these three important actions is how they form the antimicrobial action. Chlorhexidine, it is antibacterial effect. Normally a pH of 5.57. As you can see in this image, it is normally gram positive. So it reacts with the gram negative microorganism. There is complete leakage of the material and lysis of the cells taking place. And you have to know another important point is like at low concentration days, they are actually static. High concentration, they actually kills the bacteria. Another important property is substantivity. What happens is like the chlorhexidine go and attach to the surface of a particular surface, and there is a slow release of chlorhexidine over a period. That is a very important property of chlorhexidine. So recent advances you have to know, lasers are there, irrigants with surfactants are there, chitos and nanoparticles, probiotic irrigants, ozonated water. These just keep in mind whenever essays asked, you can write actually. And even natural agents like that turmeric, green tea, aloe vera, etc. is also been actually used as an intracanal medicament and is been widely studied actually. So again, diagnostic technique is very important. And talking about laser Doppler flowmetry, go with the introduction part. Why we need introduction? I mean, why we need a diagnosis? So normally, what we do in a clinical practice, we'll take an history, we'll do clinical examination, test, then radiographs, proper diagnosis and treatment. Right. So I'm not explaining all these things. This is very important. What are the clinical tests? So first, we will do the pulp test. Right. Next, we go to the periodontal test, and third is the periapical test. So, pulp test is two types. Is there nerve test? Is there? We know the pulp contain two important things: the nerve as well as the vascular, supply. Nerve test is also called as neural sensibility test. Vascular pulp vascularity test. So, cold test and heat test is normally what comes under that. That is the thermal test. Electrical pulp test is there. Anesthesia test is there. Test cavity is there. All other like the laser Doppler flowmetry, pulp oximetry, dual wavelength spectrometry, etc. All extra points actually come under the vascular supply. This is again another question being asked. What are the various radiographic or analyzing method for diagnosis? So you have to write all these things. The normal conventional radiographs which we study, then it come to digital radiographs, then it come to the TAC, then it come to CT, CBCT, micro CT is there, optical CT is there. Just write the example, and just one important point that you have to place. If the question is like recent radiographic method that is used? So cold test, various cold test method has to be actually written, like the ice stick is there, the temperature I have given. Please note down this, that this is very important that you have to write. See, again, endo ice is there, carbon dioxide, snow, and difluoromethane. Next, coming to what is laser Doppler flowmetry. Laser Doppler flowmetry, as we have discussed in the like classification, it is used for checking the vascularity. Okay, vascular supply is there. So Gazelius was the person who actually introduced this. And what we use is like we'll be using a helium neon laser and a semiconductor laser is there. Here, see, there will be source of laser being given. So there will be RBCs flowing through the blood vessel. So sometimes in necrotic pulp, what happens is like there might not be a flowing RBC. So the amount of scattered laser will be less. So that is how we actually detect. See, laser is applied onto the tooth structure. That is a fiber optic source. And what happens is like the moving RBC will actually push or deflect the Doppler, and it is detected by the photo detector. Okay. Next question is like again caries risk assessment. So I just added caries risk assessment method has been actually asked. So these are the caries risk assessment. Camera is there. Karyogram you might have actually heard, but others you can just note. It is just asked for a 3-mark question. Camera, karyogram, Dunt, caries risk model, caries risk assessment 2, and traffic light matrix model. Please write this important terms. Next, very important classification is like the method of caries removal or a caries excavation. Please note this again, very important question as I told. First is like there is mechanical methods like which we use, like the burrs are there. So first of all, we can use excavators like the discoid, cleoid, spoon excavator. Then comes the mechanical rotary devices is there. As you can see the burr, there are carbon steel burr and tungsten steel burrs are there. Polymeric burr are there. They are made up of plastic, as you can see in this image, like polymers or imide polymer. The advantage of a polymeric burr, example is smart burr and smart burr. So we know that nowadays we have a concept that we have to preserve the affected dentine, right? What happens is like this burr cut only the infected dentine. When it comes to affected dentine, this burr wears off. So that is the goodness of polymeric burrs. Next is ceramic burrs are there, like Cera burrs, all ceramic round burrs, etc., which is also used for cutting the caries. That was the mechanical method, spoon excavators and the various burrs, the polymeric burrs. Next come the chemomechanical excavation. Mainly the agents, chemicals are used for actually removing the caries. First of all, sodium hypochlorite based agents are used like GK101, Cariodex, Cariosol. Hope you have heard all these things. Go for the explanation part. Pepsin-based caries excavation is there, like the enzyme pepsin, for example, FC8. Papacarin is also another chemomechanical method. Ultrasound methods like we'll be using 25 kilohertz oscillations. Pinasono aberration is another method where the frequency will be less than 6.5 kilohertz. Air aberration where we'll be using very high speed aluminum oxide onto the surface of tooth. It remove the caries. Then lasers, very important. YAG lasers is used for actually removing the caries. So please keep that in mind. Very important methods. First, we studied about the mechanical method. Second is actually the excavation by burrs. Third is like the chemomechanical method, ultrasonic method, sonic aberration, and lasers. Next important question is like CAD-CAM. So CAD-CAM is actually a recent advancement for actually in dentistry over the last 25 years. So normally what is CAD-CAM? That is actually computer assisted design and computer assisted machine. We'll be actually scanning the patient. As you can see the image, scanning the image. Instead of taking impression, we'll be scanning through the wires will be going to the computer and the computer image will be sent to the lab. No impression, etc. will be there. Okay. So you have to know the history. Durant was the person who developed the first dental CAD CAM. And nowadays there is Cirac, AC, Lava, chairside, oral scanners. These are the most recent advancements. So why this is good? We know this is there is no infections being spread because there is no impression, there is no time is being consumed, quality is being consumed, etc. The advantage. Disadvantage is, of course, it is a capital consuming method. Okay. Uses is well, like it can be used for crown, veneers, inlays, onlays, implant, abutments, everything it can be actually used. Normally, it have a three important component that this you have to know. It have a scanner for scanning, then it have a software onto which, and there is a production technology. Okay. This is actually the thing what is happening. Teeth, instead of the conventional impression, we'll be scanning with the help of a scanner. It goes into a CAD design and it will be sent to the manufacturing. Okay, only this important point you have to know. There are a lot of softwares also. Okay. Next, the retention features of amalgam we have already studied earlier. That's the class two and inlay cavity. I have given this because this question has been asked both the essay and short essays. Please go through this. See, different question I mean asked. See, okay. So next question is like define obturation, enumerate the different techniques of obturation. This is again a very important question, frequently been asked, and I have been discussing only the thermoplasticized obturation. See, the warm, you can note this chart. Warm vertical compaction is there, lateral or vertical compaction is there, sectional compaction, thermomechanical and laser compaction is there. So normally the warm is like two methods. The traditional heat carriers like a Shielder's Boston technique and electrical like system B, touch and heat, etc. is there. So normally the warm vertical compaction, as you can see in this chart, there are two types. The traditional and the electrical method. In traditional method, it is a shielder method where we'll be actually placing the master cone that fits the radiographic apex, as you can see here, and we'll cut the master cone 0.5 to 0.1 mm at the tip of the canal, and we'll be actually placing that, and with the help of a plunger we'll be pre-fitting within 3 to 4 mm of the radiographic apex, as you can see here. See here. So the three type of plunger will be there. As you can see in this image, the larger plunger fit in the coronal portion. We will be actually fitting in the coronal portion. Middle plunger will be going into the middle third, and smaller plunger will be going 3 to 4 mm till the radiographic apex. Like that, the heat is being given and it will get actually condensed within the cavity. So that is about the first method. Second is using electrical heat carrier method is there. As you can see in this image, there are various system B techniques where we'll be using small continuous wave obturation techniques. As you can see in this image, we'll be placing the gutta parcha, and in a particular temperature of 200 degree, it will be heated and it will be actually placed within the cavity. You have to know the various plungers that is used and the tapers, like the medium is there, medium fine is there of 0.06 taper, 0.04 taper, etc. with a handpiece. And as you can see in the image, once we place the gutta parcha with the help of a down pack method, we will be filling that, we'll be transferring that heat to the gutta parcha. Okay. So that is down pack method. And last, we'll be actually backfilling that area. Okay. So, what is the advantage is like it is temperature is being controlled, heat one activated, it will be concentrated to the tip, hence it softens the gutta parcha so that the amount of voids will be less. The disadvantage is like there is a chance of extrusion and there is thermal damage being taking place. Okay. And again, lateral condensation methods is like where we'll be using Endo tech. So please keep this in mind. Endo tech is used. Next is sectional compaction method is there. As you can see in this image, a very small section of the gutta parcha will be placed within the apex. This is also called as Chicago technique. Okay. So what we will do is like a very small amount of gutta parcha that fits will be placed in the canal, and we'll be actually backfilling the this thing. Canal. McSpadden's compaction method is there. This is actually like a headstrong file. In that, gutta parcha is actually coated. So we'll be actually place that in the cavity, and this handpiece will move at a high speed, and because of that the gutta percha will flow into the cavity, and that H-shaped file will come out. So this is how you have to know. So advantage is like what is advantage? Like canal will be filled in seconds. It is very dense, void free, etc. is there. But the disadvantage is that there is chance of fracture. Again, laser is being used. We will be placing the gutta percha, heating with the help of laser, which is the recent advance that is being used. So talking about obturation, you have to know the various technique. Especially keep in mind that chart. The warm vertical method is there. Lateral method, sectional method, thermal compaction method, and laser method. So I think I have very much. So the time is very limited. I have actually discussed most important topic. So if anybody want this PPT, anybody want the content in any chapter, please contact the last number which I have given. So always be free to ask. Idento is always there to help you. So contact this number if you want this PPT, if you want any content or any chapter. Please contact. Do well, study well. Few days left. Hard work pays off. Thank you.